Okay, good morning everybody. Welcome to Anglia Ruskin on this slightly damp morning, I think. My name's Dan Gordon. I'm a professor here at Anglia Ruskin in exercise physiology. And depends how long I ramble for, but let's say for the next 40 minutes, which will give us time for questions, I'm going to talk to you really about a thorny issue, I think, which is the role of exercise in controlling and potentially mitigating against diabetes. And as I've put in the title, it is a little bit about this, is finding that perfect fit. It was a slight, obviously, play on words. But I think that we'll start with almost like a take-home message, which is there isn't a one-size-fits-all here. And I think sometimes, particularly when we talk about exercise and exercise habits, even if we take it outside of the diabetic community, we think about this notion of, for classically, a 10,000 step a day approach, which is classically advocated. But actually what we know, even with the 10,000 step a day approach in the general populace, is that actually that doesn't fit everybody. Some people actually get benefits from far less, some people need far more. So I kind of, starting with almost a take-home message, which is, if we're thinking about doing exercise or we're thinking of prescribing exercise, it will not be a one-size-fits-all approach to this. Now, if the technology works, and you're able to, and you can scan the QR code, I just want to get a sense of where we are as an audience in terms of, do I have a diabetic audience? Do I have a non-diabetic audience to talk to? Because it's interesting to who I'm maybe, am I preaching already to the converted, the unconverted? It should take you straight into the software. It always worries me when they stay easy. Oh, hey, there we go. Good. Right, people are off. Oh, okay. Don't leave me at 1-1. That makes it very hard to kind of. Okay. Oh. Interesting. Give it a little bit longer in case anybody else is able to. Right. You can't get the Wi-Fi. Oh, bless your heart. Okay, which group would you have been? You've been the diabetic group. Okay, cool. No. You're a no. Oh, perfect. Okay, gosh, the no's have it. I sound like John Bercow in Parliament. The no's have it. You're a yes. Okay, so the no's have still got it. Okay. So I just wanted to do that because it gives me a frame of reference a little bit about where we stand. And I think it's fascinating, actually, there's a large group of you here who don't have diabetes and maybe just thinking about kind of lifestyle factors and lifestyle choices. I think that's quite useful to kind of set the scene in terms of the discussion that we're going to have as we go through this. So, you perhaps will not be surprised when I talk about the notion of types of diabetes, and I start with type 1. So, type 1 diabetes is highly prevalent. It's more prevalent in childhood than it is in adulthood, so it tends to be something that is developed actually from birth. It's got a large genetic predisposition. So there is a large hereditary factor associated with type 1 diabetes. And that doesn't mean to say that you cannot get a phenotypic response for type 1 diabetes, but the predominance of it is that it comes from a genotype. In the type 1 population, what we know is that with type 1, it tends to be associated more with wider range of complications than we see with the type 2 diabetes, which I'll get to in a moment. So we know that if there is poor insulin control, and therefore by definition poor glucose control, that is associated with poor health outcomes. It's associated with development of things like a neuropathy. So if you think of what's a neuropathy is the notion of loss of a sense of pain, because we get a direct impact on the central nervous system. It's associated with a condition which we call claudication. So claudication is where we start to lose blood vessels and we start to lose the circulation, particularly in the periphery, which I'll get to later on in in this presentation. But actually, the flip side is with good insulin control, and also using all the other factors we're going to talk to today, particularly the exercise, type 1 diabetes now, the prognostic outcomes are far better than they were 10 years ago, let alone 50 years ago. But the one that's perhaps the most concern to us at the moment is actually type 2. The growth in type 2 diabetes in the UK is astonishing. And it's associated predominantly with other risk factors which are more associated with health and lifestyle. So we know that type 2 is associated with sugar intake. So we know, for example, the country, I'm going to ask you actually, do you know which country has got the fastest rate of rise in type 2 diabetes?
Guess China.
Good choice. It's not China. America? It's not America. See, America's a good one, right? You'd think America because America's already up there. There's one on the fast. Somebody said something at the back.
Mexico.
You're very close. It's Brazil. So Brazil, and it seems to be associated with the lifestyle of the people living actually in the favelas. So in the favelas, they tend to, unfortunately, have a poorer lifestyle. They tend to have access to poorer quality of foods, poor quality of lifestyle, and it's associated with the onset of type 2 diabetes. It's also associated with a lack of exercise. So we know that there's this association between if I have a reduced amount of exercise, there is a greater chance, it's not a kind of a cause and effect, but it's a greater chance or association between the development of type 2 diabetes. I'll give you the really good news. There is also the potential with exercise to actually reverse type 2 diabetes. You can't stop it, but in essence, you can in essence offset the symptoms of type 2 diabetes with particular types of exercise. So we know that type 2 is associated with obesity. We know it's also associated with other conditions like cardiovascular disease and so on. So if we have other comorbidities, they tend to be associated with type 2 diabetes as well. It is not as prevalent in childhood, although we're starting to see it seeping into childhood, because as diet becomes poorer in childhood, because we're living in a society now where we're eating processed foods, we're eating foods which are higher in simple sugars. We're starting to see it come into childhood as much as it is in adulthood. It tends to be associated with adults who are over the age of 40, and we start to see this. The thing that's quite interesting with this is there's a large proportion of the population, which I can show you in a moment, who have what we call pre-diabetes. So actually they have got the symptoms of being diabetic, but aren't aware that they are diabetic. And so that is associated with raised blood glucose concentrations. It might be associated with a raised blood pressure. But actually a vast proportion of the population are completely unaware of what is happening with the type 2 diabetes. The symptomology from type 2 is very similar to what we see with type 1. It's associated with poor control in terms of poor control through diet, poor control potentially through medication. It's associated with those poor health outcomes that we were talking about a moment ago with type 1 diabetes. So they sound like the ones that perhaps most people have heard of, but perhaps the one that will surprise you is that there is a type 3 diabetes. Now, type 3 diabetes is a relatively new construct, and it's originally identified by researchers out at the Mayo Clinic in the US, and they started to look at this and started to understand that actually if we start to see a lack of insulin sensitivity in the brain, it's actually associated with Alzheimer's disease. And there's a lot of work that's now going on that is suggesting it's not an absolute cast iron guarantee that if I've got poor glucose control and insulin, I've got good insulin sensitivity, that I'm not going to get Alzheimer's. But there's really good evidence suggesting now in large cohort studies that if you've got poor insulin sensitivity, it seems to be associated, it seems to be one of the causal factors with Alzheimer's. And it's certainly receiving quite a lot of attention at the moment. So we now have this new classification, which is the type 3 diabetic. And what is fascinating about the type 3 diabetic, it is a longitudinal effect. So fundamentally, it is not something we're likely to see in childhood. It is not something that we're likely to see even in adolescents going into middle age. It tends to be associated with an older age group. But you can see why there's a real interest in this. What we don't know, excuse me, with this is we really don't know, because it's a very, very new kind of diagnosis in many ways. We don't really know whether, for example, exercise, we don't really know about the benefits of dietary control in terms of type 3 diabetes. I think we can take a pretty good guess that actually if we've got better regulation of glucose, and therefore we have better insulin sensitivity, which comes from diet and it comes from exercise, that if this association is actually, as the Mayo Clinic are postulating, that actually fundamentally you would argue that there should be a reduction in the onset of type 3 diabetes, and theoretically a reduction in the prevalence of Alzheimer's, which would be an enormous sea change. So I think it's a case of watch this space on this one. But there is one more category of diabetes, and actually it's a category of diabetes which is actually quite common in the UK. And it's gestational diabetes. And it's the notion of developing diabetes through pregnancy. And it is actually far more common than we actually think. It tends to be associated, again, with lifestyle factors. So if we are, for example, inactive, that is, we are doing less than 30 minutes of physical activity 3 times a week, you've got a greater propensity during pregnancy to develop a gestational diabetes. If you are somebody that is eating either high calorific diet or is somebody that's eating a diet that is higher in simple sugars and high in saturated fat, there is a greater chance of getting or developing the gestational diabetes. There is also a fascinating part, which is it is more associated with second pregnancy than first pregnancy. There is also a genetic factor here. So if you have members of your family who are diabetic, there is a greater chance of developing gestational diabetes during pregnancy than somebody that comes from a family that hasn't got any history of diabetes. We finished a fairly large-scale study on this about 18 months ago, where we tracked over 200 women who were going through pregnancy, and we tracked exercise habits and we tracked nutritional habits and so on. And actually the thing that was really fascinating was pretty much what I was saying, those headline values, which is exercise was kind of a real discriminator between the population groups. And within the diet, one of the factors that we started to identify, which sounds a really kind of left field one, was actually just drinking things like milk. And milk doesn't normally stand out as being something that is fundamental in terms of glucose regulation, but actually milk plays a big role, particularly if it's a non-saturated form of milk, in terms of glucose control. So we were actually quite fascinated by that, and actually the evidence was quite clear that the individuals that were drinking more milk, so not just a case of having milk in your tea or coffee, but were actually drinking milk, we were seeing a much lower prevalence of gestational diabetes in that population group. So what we've got now is we've got 4 classifications of diabetes, 3 of which we're absolutely certain exercise plays a key part in regulating, and a key part in terms of controlling, and actually in type 2 in particular, quite good evidence in terms of its ability to reverse. Not get rid of, but reverse type 2 diabetes. Now, what they all have in common, I've gone the wrong way. Helps you press the right button, DG. There we go. What they've all got in common is these range of symptoms. So if you are diabetic, these will be very familiar to you. So we know that the classic symptom is the hyperglycemia, so that's the raised blood glucose concentration, and that raised blood glucose concentration which then leads to these adverse effects. So we know that there is, for example, decreased glucose uptake at the muscle. Why is that important? It's important particularly for things like day-to-day physical activity and exercise, because glucose is a primary fuel source that we use for movement. So if we've got a reduction in glucose being uptaken in the muscle, actually physical activity becomes much harder theoretically for us. We've got neurotransmitter dysfunction. So again, it was in the press yesterday, which is quite an interesting thing, which was a piece about being hangry. My wife tells me I get hangry. But when we are hangry, the reason that we feel hangry is because we actually get a slump in blood glucose. And actually we feel the effects of that. And if anybody that's ever been hangry knows that you probably make poorer decisions when that is the case. But the flip side is also true, that if we actually have significantly raised and continue to raise blood glucose levels, they cause this effect on the neurotransmitters associated with poor insulin sensitivity, which then links to what I was talking about with the type 3 diabetes, for example. We know that if we have poor glucose control, we get an increase in what we call lipolysis. So this is basically the notion of fat regulation. And so we start to see a greater absorption of fat. And so in males who are diabetic, we tend to see a greater absorption of fat within the belly region. We see the same in females, but also in females we tend to see it around the buttock region as well. They tend to be kind of primary markers for us in terms of what we're looking at. So there's an awful lot going on. I won't go through all of these, but fundamentally all of these are kind of effects of having a continual raised glucose concentration. And many of you are probably going, well, what do you class as a raised glucose concentration? Well, an average or a standard glucose concentration, blood glucose concentration fasted. So this would be following a 24-hour fasting. Should be in the region, and again, as I said at the start, there isn't a one-size-fits-all, should be in the region of about 3 to 5 millimoles per litre in a standard blood sample. If we see a persistent concentration that is into double figures, then it's an indication of either pre-diabetes or diabetes. I've seen participants and patients coming through the labs who have a very, very poor glucose control with concentrations of over 40 millimoles per litre. I mean, that's a real hyperglycemic effect. So as long as that concentration is around about that kind of 3 to 5 millimole per litre, then actually you've got a very, very stable, a very normal blood glucose concentration. Don't be surprised if you do blood glucose readings and you're taking this, don't be surprised in terms of those values fluctuate a lot. So if you are taking a blood glucose reading, you need to take it at the same time of day. I'm sure many of you that are doing this already know this, but it's perhaps worth just reminding. You need to take it at the same time of day. You need to have taken it doing exactly the same routine. So if you change your routine, you change the blood glucose concentration. It's affected by just, for example, just eating or drinking will affect, you'll get a sudden surge in blood glucose. The other thing that's quite interesting is where you take that sample from. So conventionally, we take a blood glucose sample using a finger prick. So you take the finger prick, you jab the finger, out comes the sample. The bit that perhaps most people are unaware of is if it's at all possible, you want to hit the same spot every day. And the reason you want to hit the same spot every day is running through that finger, you have capillaries, which is in essence what you're jabbing, but you have capillaries which contain arterialized blood and capillaries which contain venous blood. And depending upon whether you hit an arterialized capillary or a venous capillary will change the blood glucose concentration. So we always try when we're in the lab, and the participants aren't great fans of this, we try and hit the same spot every time because it guarantees us, it doesn't matter whether I'm on the venous or the arterial side, it guarantees me a standardization in that blood glucose concentration. So, we're setting the scene. We're kind of getting a sense of the ramifications of diabetes. What I thought I would show you is the bit that scares me, which is this. So this is the data that we now have. This is government-based data, which shows us the projections for diabetes in the UK. So that is into the millions. So we're looking at approximately now, we've got about 4.4 million people who have diabetes, and that's across the three forms, the predominant being the type 2 diabetes now. We're looking at around about 4.9 million by 2035, based upon projections. However, there is a lot of potential variability in that value, not at the moment, interestingly, going negative. It seems to be that actually, depending upon kind of the projections that you read, it looks fairly linear at the moment. But the projections that we've seen are that, yes, 4.9, but it could be up to anything like 5.3 million people. So quite a large variability. What's the ramification? Well, there's a huge economic burden associated with diabetes in the UK. It costs hundreds of millions of pounds to treat diabetes each year. The average cost of treating somebody with diabetes in the UK is anything from about £7,500 to £15,000 per year, depending upon what they go through, whether it's from medication all the way through. So particularly with type 2, if we can actually down-regulate that, we can actually start to reduce things like economic burden and so on. Where it's quite fascinating is if we then look at the prevalence of diabetes regionally. So we can see, and this is kind of going to show you over time, I'm going to go further forward in a moment, but you can see fundamentally where the prevalence is. And actually one of the things that we're starting to understand is that there is a socioeconomic stratification for diabetes in the UK, as there is in the US, and as I talked about in Brazil. So areas that have got greater wealth tend to have lower incidence of diabetes. And in fact, if we look, coming further forward, that's the projection. So actually, we're starting to lose that social stratification, but you can still see that the prevalence is very, very, very high. Scotland, we've taken out the equation. If anybody is Scottish, apologies, the rate in Scotland is enormously high. It's the highest rate of any country in Europe for diabetes is in Scotland. So it's not one of those things where you go, oh, this is kind of, a health warning, but it's not really there. It's one of these kind of urban myths. It's genuine, it is real. And I think the thing to tie with that, which is, although there isn't a direct cause and effect relationship, I think it's worth bearing this in mind. Because diabetes is linked to other health outcomes, and I mentioned earlier on that the prevalence of type 2 starting to develop in childhood, is the connection that we're starting to see now between that and physical inactivity and the rate of obesity in childhood. So in the UK now, 1/3 of the entire population is now classed as clinically obese, 1/3 of the population. In the US, they're just bordering on 2/3 of the population are clinically obese. When we look at physical activity, the standard recommendation from the government, which is an underestimation because it's a way of kind of fundamentally encouraging us to do exercise, I'm sure most of you are aware, is to do 150 minutes of physical activity, moderate intensity activity per week, or 70 minutes of inverted commas high intensity activity per week. What we've seen in the age group, which is 18 and below, are significant reductions in the amount of physical activity those groups are doing. And in fact, in the last National Fitness Survey, there was a population group, I won't tell you the location, but I'll tell you the region, which is in Cambridgeshire and Peterborough, of 14 to 18-year-olds who were doing less than 30 minutes of physical activity per week. And I scratch my head. I don't quite understand how you do that little, because that's kind of getting out of bed, going down the stairs. I don't know, but that's kind of what the data is, and that's the worry. Because physical inactivity is associated with obesity. Obesity is then associated, not causal, but it's associated with a greater risk of developing particularly type 2 diabetes. And then the type 2 diabetes is then associated with the risk factors that we were talking about a moment ago. This is what it looks like globally. So fundamentally, globally, we're seeing enormous increases. We're seeing large increases, as I said earlier on, in South America. North Africa now is showing large increases. So globally, we are seeing significant rates of rise in diabetes. And in fact, you can track this data online. It's a fantastic portal through the WHO, World Health Organization, which allows you to track this data annually. So it is a global issue, and it is not just a UK-based issue. So it all sounds a bit like doom and gloom. And it all sounds like it's a terrible, terrible situation. So where does exercise fit in with this? Well, there is a term that has been developed in the US, which I think is actually a really good term to describe it, which is exercise is medicine. And there is a whole campaign which came from the American College of Sports Medicine, which is absolutely in that domain, which is we need to view exercise now as being a medication, and actually it's something that should be prescribed. I think it's a really good term for this. We know, if we think about the health benefits of doing exercise without diabetes, I'm sure many of you in the room are fundamentally aware of the take-home messages, that it reduces the risk of cardiovascular disease, being physically active reduces the risk of a number of cancers, it reduces what we're going to get to in a moment in terms of diabetes, it reduces the risk of respiratory diseases, metabolic diseases, and it increases longevity and lifespan. It is also associated with increased cognitive function. And we've seen some data on this, and we've produced some data on this in a range of population groups from kind of able-bodied all the way through to Down syndrome, where we've demonstrated that actually just being physically active actually fundamentally fostered significant gains in cognitive function. And of course, as we get into older age groups, that becomes a really important aspect for us to kind of think about. So what do we know then about exercise and diabetes? Well, these are the basic take-home headlines. So what you've got here is, this is on the x-axis, we've got the duration of exercise. And then the three bar colours represent intensity. So the purple bar is low intensity, and we'll define what we mean by low intensity in a moment. The yellow bar is kind of moderate intensity, and the green bar is high intensity. Now, to a certain degree, what they're showing you is the ability to control blood glucose concentration. And you can see that the ability for blood glucose control is a function of duration of exercise. So if you do longer duration exercise, you have better control of blood glucose concentration. But what it also shows us is that there is this slightly curious relationship with intensity of exercise. That actually the simple notion of just doing intense exercise, which is something that's advocated quite a lot, which is high intensity exercise, it's quite a big trend now, which is the notion of doing HIIT-based training, which is high intensity interval training. It actually doesn't seem to be any more beneficial than what we're seeing if we do moderate or low intensity exercise. So let me convey moderate and low intensity. So low intensity exercise is simply the notion that if you want to equate this, it's like going for a gentle walk. That's low intensity exercise. With moderate intensity exercise, you're looking at something in the region of a heart rate of about 140 to 150 beats per minute. It's not particularly high in terms of the load, but you will feel that you're doing a little bit of exercise, whereas the high intensity exercise is really anything beyond 150, 160 beats per minute. So you're getting a benefit irrespective of what you're doing. So even if you're doing less than 10 minutes, you can see here that it actually reduces blood glucose concentrations. It's beneficial. So even if you are working with people who are not particularly physically active, and you can encourage them to just start exercising and they just do 10 minutes of exercise, it is better than doing no exercise. I'm a huge advocate. Being active is better than being inactive. It doesn't matter how much or how little we do, it is better than doing nothing. But as you increase the duration of the exercise, what you start to see is fundamentally that there is an increase in the ability to reduce the blood glucose concentration. But if we make the intensity too high, as we start to see as the duration increases, particularly if we get to beyond 30 minutes, which is kind of the natural government guideline, which is conventionally what people think about, is 30 minutes of exercise, it actually isn't as beneficial to do the higher form of intensity of exercise as it is to do the moderate intensity form of exercise. So that's kind of a really important take-home message. And if you're thinking, well, I don't like the notion of exercising, I don't like this idea of conventional exercise and so on, which we'll get to in a moment, equate this maybe into kind of daily chores, okay? So if you're doing work in the garden, so if we're talking about, for example, weeding and that kind of work, that falls into our moderate intensity category. If you're doing digging, that would fall into our high intensity category. If you're potting plants, I sound very middle-aged saying this, if you're potting plants, that would be your kind of low intensity form of exercise. Even housework falls into this. So housework have these what we call METs. So these are measures of energy expenditure. So housework, for example, if you are doing vacuuming, Everybody's looking at everybody else going, who's doing the vacuuming? If you're doing vacuuming, actually it falls into the low intensity exercise. But if you're sweeping, you'd fall into the moderate intensity activity. So it doesn't even need to be, get your trainers on, go out and exercise. It can simply be just being active is going to have a benefit in terms of things like glucose control. And the key has to be, remember we said hyperglycemia was the issue. So the key's got to be trying to bring blood glucose down. So what do we know? Well, we know that cardiorespiratory exercise is one of the powerful mediums that we see with this. And what you can see in the data set here is a 24-hour response in terms of blood glucose. We've got kind of fasted and a non-fasted condition. But what we know is if we kind of track blood glucose over a 24-hour period, and what they've got here is they've got high-intensity interval training. And I mentioned earlier on about the potential for reversing type 2 diabetes. This has actually been demonstrated in a small number of studies using high-intensity interval training, which sounds counterintuitive what I was mentioning a moment ago when I said, well, hold on, high-intensity exercise doesn't seem to be beneficial. The trick with high-intensity exercise or high-intensity interval training exercise is it's actually a very short duration. So we're looking here at exercise of probably in the region of about 2 to 5 minutes, but actually really, in terms of heart rates, we're getting close, if not at maximal heart rate. These are very short, sharp bursts of exercise. So this is not the kind of exercise that you would recommend to somebody who has never exercised before. This is not the kind of regime that you'd recommend to somebody who is already physically unfit. And I think that's one of the mistakes we make with recommending things like HIIT and sprint interval training is that the headlines are, it's really beneficial. It has all these positive benefits. It does, but actually if you read the literature, they generally run these studies on already relatively physically active population groups of students who just happen to be diabetic. If you take a group that have been inactive, you should not be using high-intensity interval training. There is too much risk associated with it because you're putting the body under an awful lot of strain. But if we do lower intensity cardiorespiratory exercise, as we saw in the previous slide, it really is beneficial. We know that it doesn't matter actually whether we are doing smaller blocks of work, so that is say 10 minutes of work, and doing that 3 times, or doing just a 30-minute block of work. Both actually produce the same benefits. So it's a great advocate in terms of, particularly if we're trying to get people to be physically active, it's of great benefit to us to actually think, well, actually, I don't need to do that classic 30 minutes of exercise. And particularly in today's society where I think one of the major limiting factors is time, or people will tell you the major limiting factor is time. Well, actually, you don't have to give a full 30 minutes or a full hour to exercise. You can fundamentally do this by breaking into smaller blocks of exercise. And we know that individuals that have got cardiorespiratory exercise in their medication package have greater glucose or better glucose control, better insulin sensitivity, lower blood pressure, and all the kind of the comorbidities that are associated are significantly reduced. But I said earlier on, it's not a one-size-fits-all. And what we started to understand now is actually strength training and actually putting load through the muscle is as beneficial, if not more beneficial, than cardiorespiratory-based exercise. And this is quite an interesting data set. So this is basically the amount of time that's being devoted to strength training. And then what you've got is fundamentally the reduction in type 2 diabetes. So it is quite powerful. Now, what are we talking about with strength training? Well, this is a fairly broad church at this point. You need to be thinking about if strength training is maybe something that's perhaps more appealing, or we're thinking, well, you know, it fits perhaps with more what I do in terms of work, then it needs to be relatively heavy loads. Well, that doesn't sound very scientific, Dan. How heavy is heavy? Well, we tend to be talking about if perhaps you're maybe somebody that goes to a gym. We're talking about maybe 80 to 85% of the maximum amount that you can lift. So it's quite heavy in terms of what we're asking people to do. But actually, the amount of work you're asking people to do is just 3 sets of 5 repetitions. and we see these benefits. And the reason we see these benefits is, one, we know there is a genetic component going on here. It's related to a key gene, which is a key regulator of exercise, which is called mTOR. mTOR is not triggered during cardiorespiratory exercise. The primary genetic regulator during cardiorespiratory exercise is what's called PGC1 alpha. But mTOR has a significant role to play. And what we know is, one, you're going to increase things like muscle fiber size and proliferation of fiber tissue, but that's not really important. The key thing actually in this is what's happening almost certainly in the recovery. And in the recovery, you are actually upregulating all the factors that are associated with mitochondrial function. That is the powerhouse for oxygenation in the tissue. And if we put more strain through the muscle, then we have a greater tissue demand in the recovery. And it is that tissue demand in the recovery that seems to be the factor that is promoting this reduction in type 2 diabetes. And not to float over this, both the cardiorespiratory and the strength training are both also associated with increased immune function. So the susceptibility to catching infection is significantly reduced if we're physically active. And there's a fantastic association, Nieman's J. And Nieman's J is, if you imagine a kind of a J shape like that, and you imagine on the x-axis, I suddenly realized I should have put this as a slide. You imagine this on the x-axis, this peak of the J here is associated with inactivity. As we become more physically active, we go into this nadir. And then if we become highly, highly active, we go up this side here. What's the y-axis? Well, it's basically upper respiratory tract infection, the common cold. So if we're moderately physically active, we actually have much, much better immune function. If we're highly, highly trained, actually our susceptibility to colds and infections is far more prevalent. And actually, if we're very unfit, our susceptibility to colds and infections is also highly prevalent. And in a diabetic population group, we've already got associated cofactors, and then we have an immune suppression, then the effects are prolonged and the effects become more serious. But one of the things that we've noticed is there is a lack of people in the diabetic population group who actually exercise. So the proportion of the general population who exercise, as I mentioned earlier on, is falling. But actually within the diabetic population group, it has always actually been relatively low, despite the fact that it is recommended for the NHS, despite the fact if you have an annual health check, I'm sure it's recommended. But this word map really tells you why people don't exercise, or why there is kind of this barrier to exercise. The obvious one is the fear of low blood glucose. I was advocating reducing blood glucose because of the benefits of reducing it. But there is that concern, which is, will I do too much exercise, I get hypoglycemic, and that actually becomes really quite serious. People are really worried about that. They're worried about body image, just lack of motivation, lack of enjoyment. So there's a lot of things we have to kind of consider within all this. And then there is the population group who can't exercise. So we have a large population group within the diabetic community who are suffering from conditions like neuropathy and are suffering from ulceration. So these are significant side effects from diabetes. See it mostly in older adults, but we are seeing it, as I say, we're starting to see it in people who are middle-aged. It's, as I say, it's the association with poor glucose regulation, poor glucose control. And if I've got a neuropathy, it's painful to then place the foot. If I've got foot ulcers, then the issue is that I can't wear shoes, I can't wear socks because they rub on the ulcer and they are an open wound, and I get weeping and I get bleeding and it's very, very, potentially very, very nasty. The long-term ramifications of this population group, and this is one of those statistics that when I say it, people go, no, really? In the UK each week, there are 186 amputations from diabetes located in the lower limb. 186. And that's mostly associated with type 1 diabetes and poor diabetic control. So what I'm going to show you now is the final part, which is where we've gone. and what we're thinking about in the population group, and also how this may be beneficial, particularly to people who fit into these groups, which is, I'm really not comfortable going out to exercise. I'm really concerned about being outside. I'm really concerned of all the ramifications of exercising. What can I do? So we've started to use something which is completely counterintuitive. It's a technique called ischemic preconditioning, and it sounds completely left field, but it's very, very cool. Under ischemic precondition, which is what you can see on the data set here, what we do is we apply a blood pressure cuff. So in our diabetic foot patients, we're applying we're applying a blood pressure cuff above the ankle, because we want to facilitate improvements in health in the foot. Just as you would do when you go to the doctors, we then inflate the cuff. And we inflate it to a designated individualized pressure. So it's not really high like when you go to the doctors, but it is high enough that it's actually going to cause an occlusion. So we occlude predominantly venous return, but there is also some occlusion of arterial inflow. The net result is what you see here. So what you see is the oxyhemoglobin with the O2HB. You can see the O2HB declines as you apply the cuff, and then the HHB, which is the carbon dioxide on the hemoglobin, rises because you're fundamentally making the cell hypoxic. None of this sounds like it's beneficial. If I then release the cuff, what you suddenly see is that spike. That spike is what we call a hyperemia. And that creates a shear stress. It fundamentally puts a bit of stress into the capillary, into the artery. The net result of this is, over time, we reduce the rigidity in the artery, and we increase the amount of oxygen that we can get into the tissue. And if we can increase the amount of oxygen we can get into the tissue, we can reduce tissue ulceration, we can increase vascularization to the region. Now, we've tried this in the foot, and I'll show you some data for this. We've tried this in the foot, but you can see the potential benefits of this, particularly if we've got individuals that are unable to exercise, because it's a simple case. How long do we have to do this for? It was 7 minutes of occlusion and then 7 minutes of reperfusion. We just did it 3 times. And you just did it 3 times a week. It was very, very simple approach. And this isn't a new approach in terms of the technique. This is actually from medicine. We've been using this in medicine for a long time, clamping organs during surgery. It's quite a logical approach. And this is kind of what it looks like in terms of the effect. You reduce the blood flow, you create the vascular shear. It has the direct effect then on central parameters, but we're more interested in what's happening in the periphery. And we know there are also benefits here which we call remote benefits. So at the moment, we've been focusing on the foot to improve the health of the diabetic foot. But if I move that cuff and I say, do the work on, say, the femoral artery, now I cannot clamp the femoral artery completely. I cannot do that, but I can stop venous return. What we now start to see is there are benefits. If I clamp the right leg, I see a benefit in the left leg, because there's a remote effect because I'm changing central circulatory responses. Now, I thought it might be interesting just to show you this. You don't have to do this if you're a patient going through this in terms of trying this at home, but this is how we actually did this with our participants. So, amazing people that volunteered for the study. So what we did was, this is a device called a dynamometer. We've got them lying supine. We're measuring their oxygen consumption. The foot is clamped, and then what we've done is we've cut a hole into the shoe, and we've inserted a device called a near-infrared spectroscopy that records the amount of oxygenation in the tissue. We've cut the toes out of the shoe. We've now got what's called a laser Doppler on the toe. That's recording blood velocity. And I'm also recording tissue temperature and so on. And then what we've had them doing, which is what you're going to see, just a snippet of this, we've had them exercising in this scenario, because we wanted to see what the response was under exercise conditions. So what we're doing is plantar flexion extension, so we've localized the foot, and then we're able to record in real time the amount of oxygen that is being consumed in the foot. Now, you clearly wouldn't do this at home. This is kind of for us in terms of getting data and data collection from the study. So what did that show us? Well, this is what we saw. We had two groups. The IPC group is our actual experimental group, and then we had a sham group. The sham group is quite interesting, that in the sham group, we inflate the cuff, and you can feel the cuff going up, but we inflate it to a pressure that actually does not reduce occlusion at all. It's really cool. You get this psychological, I can feel the cuff going up. So what we see is, if we look at the data that we've got here, what you can see is this is our SO2, so this is the degree of saturation. How saturated is the tissue with oxygen? There's a massive increase in the amount of oxygen that we're saturating the tissue with pre to post intervention. We just did a 4-week intervention with our participants, whereas the sham group, there was really no change in the data. I'm going to whistle through the data fairly quickly to do this. This is the measure of total amount of oxygen consumption in the foot in the bottom panel, which is the VO2 max. So you may have heard of VO2 max. You test this in athletes. We tested the VO2 max of the foot, the volume of oxygen the foot was consuming. And the fact that the volume of oxygen has gone up is an indication that we've increased vascularization to the foot. So not doing conventional cardiorespiratory or conventional strength-based training has actually proven to be very beneficial in terms of this response. So how? Well, this is the work from Chloe French. So Chloe's coming very close to completing her PhD now, so I can't take credit for this schematic. But these are the potential responses that we see in terms of clamping and then releasing that idea of an occlusion and a reperfusion at the foot. You'll see some of the factors we've already talked about. You'll see in here PGC1 alpha, but we see things like the key one at the bottom that I want to focus on is we get this increase. You get the hypoxic environment, so that is we create more carbon dioxide in the cell because we stop oxygen coming in. It triggers what is called HIF, which is hypoxic inducing factor. That triggers VEGF. So VEGF is a genetic component that is associated with vascular growth, and we get angiogenesis. That is, we fundamentally grow blood vessels, that is capillaries within the region. It's also associated as a side product with hypertrophy. What is hypertrophy? It's the increase in the size of the tissue, as you would see with strength training. So simply just doing an occlusion reperfusion actually touches both the kind of the more vascular cardiopulmonary responses that we saw in the earlier panels and also the kind of more strength-based responses. So there's potential for a lot of adaptations that we're looking at here. So I started with the take-home message, and I'm going to leave you with the take-home message, and then we'll open up for a few questions. And this is really, I think, the take-home message. I think we really have to move now to exercise and physical activity really being prescribed as part of any diabetic treatment. It should be part of the course, okay? As opposed to just medication alone or diet alone. We know the benefits are really, really powerful in terms of what it can do, and not just in terms of the diabetes, but actually in terms of overall health concerns. And for the population where exercise is not possible, and not just those with diabetic feet, but fundamentally we have population groups who are elderly, inactive, infirm, then using the approach which we're talking about, which is the ischemic precondition, has a real benefit in reducing the neuropathy, the skin ulceration, and actually provides a really safe and viable alternative for increasing the health of the foot. Now, if we can do that, we can potentially make people more mobile and actually then get them to be more physically active. Okay, at that point, I'm going to leave it there, and I'll open it up for questions if there are any questions. And we've got a roaming microphone here as well. So, if you've got any questions, throw them out. Oh, right at the back. Hiya.
The ischemic preconditioning, obviously there are population groups who aren't diabetic who also might benefit from
Yeah.
that. But in things like, say after surgery or something, if you have people who are very high risk of, say, further blood clots, could you improve recovery and reduce ulceration by doing that post-operatively?
That's a very smart question. The answer is yes. And in fact, I would like to say that we take credit for this. It has come from surgical practice. So it was originally used in surgery, in surgical conditions. I've not seen it used in recovery, but we have been using it with athletes in recovery. And we know that it fundamentally enhances recovery processes. So given the kind of the adaptations that Chloe was putting on that schematic, then I would absolutely say that in certain population groups post-surgery, it would be incredibly beneficial, yeah. Yeah, great question.
A very, very simple question. The strength training slide you showed, had 120, what was the units on that? Was that per day?
Oh, per week.
Okay, thanks.
So it's per week. Yeah. No, so, and again, yeah, and no, it's a great question. And in fact, it's a bit like I was saying with the cardiorespiratory exercise. The thing we now understand with strength training, there was a whole ethos really that's been pervading within the science probably for about 30 years, which was you had to do a large block of strength training on a day to get the benefits. Actually, the evidence is now really starting to come out with better controlled studies that you don't need to do that, that actually fundamentally, as long as you are hitting, crazily, this sounds crazy, but as long as you're hitting 3 sets of 5 repetitions on a single day, you will get a benefit. Now, clearly, I may want to work more than one muscle group, but even if I work 2 muscle groups, I'm only doing 6 sets of 5 repetitions, so the total amount of time that I'm engaging is actually really quite low, and I only need to do that a few times a week, and I can build up to the 120 minutes over time. And again, you would never throw somebody in at the 120-minute mark. You would always start them and gradually increase the work they're going to do. Yeah.
With reference to the, can you hear me okay?
I can hear you.
Yeah. With reference to the people who have mobility issues, so what are your thoughts on these pieces of machinery that you can plug in that are being promoted by the likes of Ian Bolton?
I think that's what you were going to
I'm presuming that, the benefits are to exercise the long muscles in the legs.
Yeah.
But what are your thoughts on that kind of equipment?
Good question. I'm assuming I'm amongst friends. I mean, there is no evidence for them. So there was a lot of work that came out in the early 2000s about a technique called vibration therapy, and it was quite rife, which was this idea that you stand on a vibration platform, and by vibrating the lower limb, the theory was that it increases muscular strength, because the idea was that the muscle is shaking and it increases strength. And then it suddenly was on, it increases vascularization. Actually, the evidence for any of these is spurious at best. So the stuff that they're talking about, which works on a similar approach, it's not fully vibrational, but it works on a similar approach. There is no real evidence for it. And I think the key with all of this is that you can find in any walk of life, you can find a study that will show you a positive, and I can find a study that will find a negative. The key is that we have to have studies which have got large-scale interventions that have done it over a prolonged period of time, and at the moment there isn't that for it. And I know that one of the things that's often talked about is using, for example, hot water. This sounds a really weird one, but if you put a limb into warm water, it fundamentally causes a vasodilation. And if you put it into warm water, I get a vasodilation. If I do that kind of what we call contrast therapy, so I put it in hot water, cold water, hot water, cold water, I get a vasodilation, a vasoconstriction, vasodilation, vasoconstriction. It's fine, and it would work, but I couldn't use it with my diabetic foot population group because of things like open ulcers, open wounds. And the effects are far less than you would see, for example, using the clamping base. So I think at the moment, it's a slightly long answer to your question. At the moment, I just don't see the evidence to support them. Having said that, if people feel the benefit and are going, actually, I'm getting benefit from it, who am I to say that it is right or wrong? But I think as a scientist, I would always look for the kind of the magnitude of the evidence.
Hi. If you are type 1 diabetic and quite active, how do you keep what advice do you think you have for keeping your blood sugars relatively stable when you're at risk of hypoglycemia?
It's a really good question, isn't it? Yeah, it's a really good question, and I think again, it's very individual with this, and I think there isn't a one-size-fits-all. And I think one of the things that we've started to understand is that if you're type 1 diabetic, you're going to exercise, is thinking about what do I need to do in terms of glucose going in before I exercise. So not necessarily exercising on a completely empty stomach, for example. So it might be that it's not to create a hyperglycemic effect, but it might be that you have some carbohydrate-based foods that are going in before you exercise. So you fundamentally get a raised blood glucose concentration to compensate for the hypoglycemic effect that you may get during the exercise. It's also worth looking now. There are a number of the sports nutrition companies that now make supplements that are suitable for diabetics to exercise. One of the misgivings for a long time was a lot of the supplements that they provided, like the carbohydrate supplements, were obviously very high in sugars, although not simple sugars, high in sugars. But actually companies like Science in Sport have started to develop sources which are fundamentally synthetics that do the same or have the same effect. And we're even getting now into the realm of understanding that some of you may have come across the idea of using gels in exercise. These are used a lot by marathon runners. The problem with gels is, again, they're quite high in concentration, but we're starting to get to the idea now that actually simply having a very, very small dose of carbohydrate, but dropping it under the tongue, so in a small micro dose, is actually as beneficial as taking a larger dose, a large bolus, which then has to be ingested into the stomach that way. So it might be, it's kind of a long answer again, it may be looking at kind of what you're eating before you're exercising and then thinking about whether there are these additional kind of resources that you can use, particularly I think if it's more endurance-based exercise. And then the final thing I suppose to think about, which we do know is associated with hypoglycemia, is temperature regulation. And ensuring really that you control your core temperature. How do you control your core temperature when you're exercising? Fluid intake, but not cold fluid. So one of the things, again, quite often I think we think is we've got to drink cold fluid because cold fluid makes it feel better. Actually, a warmer, tepid fluid is a better controller of your core temperature. If you've got a good control of core temperature, you have a better regulation of blood glucose. Okay.
Is there a time of day in which exercise or like a part of your routine where exercise has a more effective impact on reducing the blood glucose spike?
Cool. That's a great question. And unfortunately, there is a long answer to this, which is exercise per se, all exercise, as all bodily systems focus on, what's that? I've made a new word. Focus on diurnal variation. That is, there's circadian variation in all bodily systems. So if I give you kind of just a starting point, your body temperature fluctuates throughout the day. Your height changes throughout the day. So we know, for example, if I'm going to do cardiovascular exercise, I actually get the best benefits from cardiovascular exercise late afternoon. And that is because of a confluence of all of the factors that are associated with that. Because each body system has its own diurnal variation. The same with strength training. So in terms of glucose regulation, we have to kind of go against the grain a little bit. And you kind of have to go, well, if glucose regulation is fundamentally the more important aspect, and actually that's the bit I'm really interested in, which kind of relates to that slide where people are saying actually it's the major concern is going hypoglycemic, then actually what we start to understand it's mid-morning. Now that may be because you may argue, well, that's because I've had a meal before, but even when we look at people in a fasted state, actually you tend to get a better effect kind of mid-morning than you do early morning. And even though that the cardiovascular benefits are greater in the afternoon, we actually get a diminishing rate of return on glucose control. And when I say mid-morning, I'm really talking about 11 a.m. till 1 p.m. Seems to be kind of the beneficial time period. It's a very cool question. Anybody else? Yeah.
So with regards to stimulating the VO2 in like foot patients.
Yeah.
And you said that was appropriate for people with like ulcerations, but how does that work? Is it finding a limb to work on that doesn't have as many ulcerations?
Yeah, it's a good question. I mean, the thing that we did with our population group was we originally ran that study with a non-diabetic population group. It's amazing what you can get students to do. And that kind of gave us the framework for it. And then what we did was we then took people using what is called the King's scale. So the King's scale is a scale that is used to rate ulceration and neuropathy in the foot. Now, what we didn't do was go for people at the top end of that scale. So we took people in the mid-range. So this will be people who have got evidence of diabetic foot, but people who haven't got open wounds. Because one of the concerns which we had was, because of using the probes, the electrodes, what we don't want to do in a foot that is already susceptible to ulceration is create ulceration by applying these devices to them. So we clearly didn't take people with open wounds, but in individuals who had diabetic foot, yes, they fit into that category. Yeah. Oh.
So with reference to stored fat and particular reference to the work that's been done by the likes of Jason Fung and the merits of fasting and intermittent fasting and achieving autophagy for that healing potential. What are your thoughts about this? I'm thinking about the diabetic patient that's not menopausal or postmenopausal because their demand for certain nutrition is different. I'm also thinking that it's possibly not beneficial for type 1 patients. But for those patients who have got fatty livers, non-alcoholic fatty livers, I've seen in my area of work that they've taken on this regime of intermittent fasting with a 6 to 8 hour window for a number of months, and they've actually put their diabetes into remission. So what do you feel about that? I do believe that these patients are continuing with their mobility, so they're walking 5k a day, understanding that exercise is part of the treatment. But I've seen lots of positive results, and I also feel that there is huge potential for treating and managing chronic diseases by doing this kind of lifestyle.
It's a good question, isn't it?
Like you know, if you eat like your grandmother, then you're more likely to be more healthier. And then going back to the hunter-gatherers, they ate and they achieved autophagy. They managed to go for long periods of fasting, and their thinking, their thoughts, the way they killed that animal was so in tune with what they wanted to do, without having any concerns or worries about the running and the actual cortisol that's being produced to hunt that animal. So I think we can take lessons there.
Yeah, I mean, it's interesting. So we side shoes, we've done a lot of work in the past with a group at Cambridge on hunter-gatherers and looking at kind of the physiological response in hunter-gatherers. And I think the hunter-gatherer argument is quite an interesting one, but we've got to be slightly careful, of course, in the hunter-gatherer. Very, very different environmental conditions, very, very different nutritional conditions. So although they were fundamentally a hunter-gatherer, they were forced to be a hunter-gatherer. So they didn't choose to be the hunter-gatherer. And so the evidence, I like the argument, but I think I'd be slightly careful in going, well, that's the evidence for it. But I think the evidence that you're talking about perhaps is more akin to perhaps what we see in previous generations where food was more scarce. And when food was more scarce, there was a reduction, not surprisingly, in obesity and diabetes and cardiovascular disease. Now, whether we can say that actually using intermittent fasting is the way forward, I'm less sure of that, I must admit. I think part of this is that we see in other population groups is that what you've created is a regime. And what you've created is a scenario where people have something that they regulate, and they get into a routine. And so much of what this is about routine. And if the intermittent fasting approach is working, then great. But I think fundamentally it's the routine. We've got into a society now where we are a society of snackers. And we are a society where we are pickers. Now, to a certain degree, there is quite a lot of good evidence that says that if you are eating the right foods, actually it is as beneficial to have smaller amounts of the right foods, if not perhaps more beneficial, particularly in the gut biome, than eating the conventional 3 larger amounts of the good quality foods. And actually it seems to be better in terms of things like gastric emptying and so on. But in the end, I think it's about routine more than anything. I think the intermittent fasting work, my concern with intermittent fasting to a lot of degree, I think it's like a lot of things, it kind of gets into the wrong hands and I think it gets a bad press. But if they are getting a routine, then absolutely stick with, the routine is clearly working. Whether you would recommend that with all population groups, I'm not entirely sure. I mean, I think fundamentally, the key thing is a bit like the question earlier on, is about what, we're trying to create a very stable environment. And I think if you can get into a routine where that becomes the norm, then actually you're no longer intermittent fasting. That fundamentally becomes your kind of nutritional kind of regime. But yeah, I think it's an area again that deserves a lot more work to look at it. But I think again it depends on the population that you work with. So one more hit. Yeah.
You mentioned is it ischemic preconditioning as a way of improving neuropathy for those who can't exercise. If you have neuropathy and do feel you can exercise, does exercise improve neuropathy? Is there such a thing as reversing neuropathy?
That's a really good question. We can't reverse neuropathy, but we can delay the effects of the neuropathy, and exercise absolutely is beneficial. The key with it is well, what kind of exercise is beneficial? Actually, there's quite good evidence that strength training is probably even better than cardiorespiratory training for this. And again, that's a certain degree because with the strength training, there is much, much more neural controls than there is with cardiorespiratory exercise. So I think, if you've got somebody who's got a neuropathy, my advice would always be to exercise because the benefits far outweigh the inactivity and the inactivity responses that we get. Yeah.
One more question?
Yeah, go for one more.
Thank you for the wonderful talk, and it's really exciting to see this kind of finding for a PhD. The question is related to how does this translate for the common man? How, particularly in the situation of a bedridden person who cannot do exercise and is diabetic, without any scientific equipment, how can
Yeah, okay. So how does it translate across to everybody? I mean, it's a really good question. So, I mean, if you take kind of just general exercise, so we take kind of not the ischemic preconditioning response, then really it's accessible to anybody. We can all fundamentally, if we're capable of exercising, we can walk, or we can. I mean, walking is the most simple one. It's the cost-effective one. It's the easiest one that we can do. We can walk, we can jog, or whatever. So it is absolutely accessible. Even doing kind of activity, as I mentioned earlier on, the kind of the chores at home. I think that's the thing, the distinction between exercise and physical activity. We can all fundamentally find ways of being physically active. Even down to now the notion, I think a lot of people thought this was kind of like one of these trends, standing desks, walking meetings. Because if you think about kind of a work day in an office, most people sit in an office, you're sitting down for 8 to 9 hours. Actually, standing desks are highly, highly beneficial. Why? because actually fundamentally you're forcing the blood to work far harder against gravity in terms of the venous return. That promotes greater gains in vascularization and vascular flow, far more than you'll get seated. It's much better for posture, and posture then has the kind of the long-term effect in terms of mechanics and so on. But the ischemic precondition, as an example, actually what we're showing with that is you don't need an awful lot of equipment. You fundamentally just need a blood pressure cuff and a regulator to blow that up. The key is with it is that what I'm not advocating is you all go home today and suddenly go, well, I'm going to do ischemic preconditioning and see if it works. Please don't. So at the moment, it's certainly evidence that we're trying for it, but it has to be based upon specific measurements related to your circumferences and so on. And you also we have to determine whether you're susceptible to doing it. But I think most forms of physical activity for most people are accessible. I think it comes down to really finding the one that works for you. Yeah, absolutely fine. Yeah. Thank you very much.